Hi everyone. Can everyone hear me okay? Yes? Okay. So my name is Brittany Lawrence, and today I'll be sharing the development of a self-assessment tool that can be used to evaluate Indigenous cultural competency at the organizational level. So I'm very grateful to be a guest here on the unceded territories of the Coast and Strait Salish peoples. My area of focus is Indigenous people's health, and although my background is not Indigenous, I was very honored to be working doing work in this group, and extremely fortunate to have a meaningful practicum experience. Okay. So for my practicum, I was asked to provide evaluative support to the Aboriginal Health Program, as the leadership team was in the process of finalizing their Aboriginal health and wellness strategy for the next 4 years. The Director of Evaluation was also very enthusiastic and supportive, so I completed my practicum with the Evaluation Department in Kelowna at Interior Health. So specifically, I was asked to develop a broad evaluation framework for the strategy. However, under its first priority, to advance cultural competency and cultural safety, the Aboriginal leadership team recognized an immediate need to gauge the current level of Indigenous cultural competency across the organization as a whole. So my second objective was to find or design a tool to do just that, which is the focus of this presentation. So first, just a little bit about the process, because neither myself nor my practicum supervisor are Aboriginal. In an effort to adhere to culturally competent practice, we followed the American Evaluation Association standards and completed the Indigenous Cultural Competency Core Training offered by the Provincial Health Services Authority. Next, Aboriginal stakeholders were invited to participate in a working group to collaborate on the development of the assessment tool. Members included individuals from the Interior Health Aboriginal Leadership Team and Aboriginal representatives from the First Nations Health Authority and the Provincial Health Services Authority. I then conducted a scan of the literature looking for assessment tools, and found that currently there are no standards in Canada for Indigenous cultural competency. As well, all examples of organizational assessment tools that I found were multiculturally based, which is not adequate in capturing the specific colonial history, cultural diversity, and barriers facing Aboriginal peoples. So we decided to rely upon multiple resources to develop an assessment tool and added content where there were gaps. So I'd like to use my remaining 7.5-ish minutes to answer the following questions. What is Indigenous cultural competency at the organizational level, and why is it important? And how can we measure it? So first, what is it? At the organizational level, cultural competency is the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including tailoring delivery to meet patients' social, cultural, and linguistic needs. So this is a very common definition of cultural competency, but it needs to be put into contexts for Indigenous peoples. And to do that, we need to reflect on why the system is not culturally competent in the first place, and in doing so, uncover the dominant ideologies and Western assumptions about health and healing that provide the basis for a modern healthcare system, which exclude Indigenous belief systems and worldviews. So as we know, a critical social determinant of health is access to high quality and appropriate health care. To experience the benefits of the healthcare system, one must have access to those services, but due to multiple barriers, many Aboriginal peoples are excluded from receiving high quality, relevant, and safe health care. These are some examples, which are all rooted in a history of colonization, which is a foundational determinant to Aboriginal people's health and inseparable from racism. And while interpersonal racism is the most obvious form of racism, systemic racism, which systematically gives advantage to the dominant group and disadvantages those outside that group, is recognized as having the greatest influence over health disparities among Indigenous peoples. So we need to reflect on the fact that healthcare institutions are an extension and product of a colonial history in order to address inequities at the systemic level to have any significant impact. So looking across the whole organization, how do we understand the extent the organization is culturally competent and recognize the progress and improvements that it's made, but also identify gaps and priority areas? One way we can do is with rubrics. So the term rubric is not the most common term, but essentially it's a rating scale. It's not this. That's an inside joke. So this is a rubric. Evaluations make a judgment about something, and rubrics help to articulate that judgment by assigning value to each outcome along an assessment scale from poor all the way to excellent. The values are forefront, transparent, and defined in collaboration with stakeholders. So this is a small snapshot of the rubric that we developed. It's meant to function as a strengths-based qualitative self-assessment tool that clearly articulates what success looks like in a series of standards across a gradual scale from inadequate to emerging to approaching and finally to meeting the standard within each organizational domain. So another example of a rubric we're all familiar with is our grading scale. So each of these 6 domains contain many aspects where we would expect to find Indigenous cultural competency. These are the domains that the working group and myself came up with based on a number of different tools, and we filled in different gaps, and we determined where there was overlap to put different areas together to try to have the most comprehensive and holistic look at the organization. So commonly we use indicators to measure data, which are very useful and can complement rubrics, but oftentimes they are what is most easily measurable. They are narrow in scope, quantitative most of the time, and not necessarily the most important part of what we want to examine. So rubrics, on the other hand, provide a deeper and richer understanding of an outcome and its value. The concepts we're trying to assess are very complex and nuanced. So if we use rubrics to evaluate the qualitative evidence, we can gather a more holistic and comprehensive understanding and get to the heart of what we want to know. So for example, looking at the domain governance and administration, we're considering the definition, the strategic plan, direction, and pertaining to Indigenous cultural competency of the organization, the value statements driving the organization, the different levels of leadership and their responsibilities, the orientations, membership composition, and meeting protocols. So under the standard for the senior executive team's responsibilities pertaining to Indigenous cultural competency, the criteria for meeting that standard would include there is a demonstrated leadership in cultural competency, skills and knowledge in cultural competency, in Indigenous cultural competency, and evidence of a commitment to prioritizing, implementing, and monitoring the Aboriginal health and wellness strategy of Interior Health, which would be evident in their work plans and funding commitments. The next example is under the domain Equitable Access and Service Delivery, which covers the barriers in accessing services and the whole experience across service delivery from registration to discharge. So, looking at this standard, one of the standards under equitable access is cultural climate and culturally appropriate services, wherein meeting the criteria would mean that the services reflect and support Aboriginal perspectives on wellness and healing, that spaces are available to Aboriginal clients for spiritual, religious, cultural, and ceremonial use, and that they can accommodate a large number of kin and have flexible visiting hours. It would also include evidence that healing requests of Aboriginal clients are being accommodated, for example, the use of traditional medicines, foods, and access to community healers and elders, and that all of these services are co-designed with Aboriginal partners with a mechanism for feedback from Aboriginal clients, their families, and communities to better meet their needs. So these are just 2 of the 46 standards contained within the rubric. For each standard, the organization can then look across the scale and see where they may currently be situated. Scoring can be used to track changes across time, but is not meant to reduce the rubric to a number. So there were many limitations due to the time, for example. This is still in draft stages and is undergoing review by internal stakeholders. It's also a very linear model, which is not representative of Indigenous ways of knowing. And we also did not have an Aboriginal evaluator to consult with, but we did recognize the need to do so moving forward. And this is a working document, so the criteria of what meeting looks like will continuously be changing to reflect the current values of stakeholders. As well, the data sources and methods for each standard have been identified, but they still need to be agreed upon with stakeholders. So the implications for public health are promising. Interior Health has been seen as a leader in this area and has taken many strides towards cultural competency. There's also growing momentum among health authorities to become culturally competent, as it is now mandated by the tripartite agreements. There's been mutual sharing throughout this process with Aboriginal partners, and this tool was just shared with national and provincial committees creating the standards for cultural competency. Sorry, okay. So it's a very exciting time for change. So I'd just like to thank at Interior Health, at UVic first, Victoria and Betty, and Michael, my second reader, and Kathy, my first reader, and Carmel for all your help, and also Charlotte. And at Interior Health, my practicum supervisor and very enthusiastic mentor, James Coyle, the Director of Aboriginal Health at Interior Health, Brad Anderson, my working group members, Judy Sturm, Cheryl Ward, Mary McCullough, Annie Moleg, Shauna Nevdoff, and my family and friends for coming all the way down here, and my best friend for surprising me. Making me emotional.
Thank you, Brittany. Questions, comments?
Thanks for the presentation. I thought it was really great. I was just wondering, having taken the PHSA cultural competency course and then doing all this work, what are your thoughts on the value of provincial level training versus regional, given the diversity within BC, or maybe you're thinking more national or community level?
Definitely, yeah. No, that's really important. Cheryl Ward was actually on the working group, and she's leading the ICC training, so that was really wonderful. For the standard for training, which I don't have in this presentation, that was our ultimate goal of doing regional training, because each region is so different within Interior Health. There's so many different nations, and the protocols and the cultural differences are very unique. So yeah, training, or regional training was what we were targeting or working towards. Yeah, thanks.
Thank you. Other questions or comments? No? Okay, thank you, Brittany.
Thank you.